Yeah. Good evening, ladies and gentlemen, and we welcome you all to the first of the ASCO endorsed CPOEM webinar of 2024. And I'm Dr. Vishwanath S. I'm a senior consultant in the Department of Medical Oncology at Apollo Hospitals, Bangalore, and I'll be your moderator for tonight. And tonight's webinar is on personalizing treatment in hormone receptor positive, HER2 negative early breast cancer. And this is an ASCO endorsed webinar series. A few instructions before we begin. So please ensure the internet connectivity is good to have a seamless experience. By default, all the attendees will be in mute and listen only mode. Attendees can also choose to ask questions by typing in the Q&A section, and this session will be recorded. So a few words about our organization. It's called the Creative Portal for Oncology Education and More. It's abbreviated as CPOEM, a not-for-profit organization tasked with educating practicing oncologists and trainees, and a portal for increasing access to patient resources and improving awareness globally. So we are the trustees, myself, Dr. Vishwanath S., Dr. Santosh Kumar Devdas, Dr. Rachan Shetty, Dr. Chandrakant, and Dr. Poonam Arya. All of us are medical oncologists. So the agenda for today, so we have an interesting, we're going to switch. So Dr. Nitesh Rohatgi is going to start with the strategies in assessing risk in hormone receptor positive HER2 negative early breast cancer. And this will be followed by an interesting talk by Dr. Hope Rugo on changing paradigm in the management of this subset of early breast cancer in the era of CDK4/6 inhibitors and PARP inhibitors. And this will be followed by Meet the Expert session, where we'll have fellows presenting two cases, and then concluding remarks and summary by Dr. Santosh Kumar Devdas. And we have very eminent session chairs for today. Few words about Dr. Hortobagyi. We are extremely honored to have you, sir. Dr. Gabriel N. Hortobagyi is the Chair Emeritus, Department of Breast Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. He's a past president of the American Society of Clinical Oncology and is one of the world's leading authorities in the management of breast cancer. Dr. Hortobagyi is a recipient of numerous awards, and he has over 1,100 full-length publications in peer-reviewed journals and over 140 book chapters to his credit. Welcome to you, Dr. Hortobagyi. And we also have a very eminent medical oncologist from India, Dr. Bhawna Sirohi. She is a medical director and senior medical oncologist at the Balco Medical Center in Raipur, India. She has over 400 peer-reviewed papers in national and international journals and more than 80 poster presentations to her credit. She's been a key speaker in more than 200 national and international conferences, and she's won several awards, including the Bard's Heroes Award for Medical Education and other awards as well. So we'll start with the first talk by Dr. Nitesh Rohatgi, and I request Dr. Hortobagyi to introduce Dr. Nitesh Rohatgi.
Good evening. It is my pleasure to introduce Dr. Nitesh Rohatgi, who is a senior director in the Department of Medical Oncology at Fortis Memorial Research Institute in Gurgaon. He's a fellow of the Royal College of Physicians, Edinburgh, as well as the Royal Society of Medicine. Besides being a key opinion leader in oncology in India, he has been a principal investigator for several important clinical trials and has several peer-reviewed publications to his name. He was trained in medical oncology, palliative medicine, and teenage and young adults cancers in the UK, completing his CCT in 2009. His specialty interests include breast cancer, lung cancer, gynecological cancers, and GI malignancies. Welcome, and the floor is yours, Dr. Rohatgi.
So thank you very much. I think of course, thank you very much for inviting me, but I'm honored, sir, to be actually introduced by you. I never thought the day would come that you would introduce me. So it is really a pleasure and an honor. I'll go straight to my talk. It is not going to take 25 minutes. Believe you me, that if he really wanted to discuss this could take rest of our life, but I'll try and keep it shorter than 25 minutes. The key point is the strategies in assessing the risk in HR positive, hormone receptor positive, HER2 negative EBC. Just to prelude, a patient comes with HR positivity, HER2 negativity. We do presume, maybe somewhat incorrectly, that these patients are going to be much better than the other class. So I think that is been recognized for a long time that that may not be the case. But now with more strategies, that's changing. And really, that's what we're going to talk about briefly today. This is my disclaimer. These opinions are mine, but the slides have been prepared by Novartis, and I'm aware of all the material that's on it. Ribociclib, to be very clear, is not yet approved in the non-metastatic indication in EBC at the moment. And Novartis itself, therefore, does not support this promotion, but this is a medical discussion, and that's where it ends. Very briefly, the treatment of EBC has actually not changed in more than last 2 decades, except I've added recently because we're seeing that change more rapidly now than ever before. And you can see how crowded that whole paradigm looks on the left, and we will see a big change going forward as we have understood a bit more about the reasons for failure, and in fact same treatment done differently has helped a bit. Sorry, my slides. Okay. This says the therapy recommendations actually have again not been changed. We have been debating on small percentages change on absolute DFS benefit at about 4% and was a 1 to 2% of who to use AI versus tamoxifen. Duration 5 plus 5, 3 plus 7, 3 plus 5, 5 plus 3. And that's predominantly because while these are similar, there was a clear benefit, higher the risk, higher the benefit, but the benefit was not absolute. And we were recognizing that even as far back as a decade ago. With that came in the big 2 changes, and there are a few more changes down the line, which was that in early breast cancer, whether we were giving neoadjuvant therapy or adjuvant therapy, the role of post-operative PARP inhibitor in BRCA1, BRCA2 positive patients, and now we will be hearing a lot more, including this ASCO, about the HRD, about the other HRR mutations, and seeing if there is a way forward from that. And clearly the role of CDK inhibitors, which is the new class of drugs, not new anymore, and has shown a remarkable outcome in the metastatic setting already. And it was only logical that they would go into the adjuvant setting, except that the first drug in class, palbociclib, didn't really show the benefit in the adjuvant setting. And some of us wonder why. But clearly, the drug which is being used possibly in the last in the line, which is abemaciclib, is already showing benefit and has approval in a very specific indication. And ribociclib is soon to follow with the data that's already quite positive and interesting. But the question remains, and who to consider for an extra line of therapy, which are oral therapy, which are easy to give, but famous last words, no therapy in the world, especially what medical oncologists use, is never non-toxic. So we do need to know who to give and who not to give, importantly, because we do not want to add toxicity if the benefit is minute, not there, or if the patient actually would prefer not to get the toxicity. This essentially lays the foundation of why we are talking about the high risk today. And if you look at the adjuvant therapy on the left, which is essentially ER negative, we see how patients have a much higher recurrence, but that recurrence is very early on. And as that period of about 3 to 5 years finish, there is a small number of patients, which means if it's not come, it's unlikely to come again. That may not, and that is in fact not the case with ER positive tumors, because while their recurrences are known, they keep recurring even later on between 3 to 5 years. And if you notice, even beyond 5 to 10 years, up to 15 to 20 years. And it has been a lot of research with somewhat debatable, not so clear answers. as to who are these patients exactly who will recur later, but more importantly, what can we do today so the recurrences are delayed later? One of the key examples of tamoxifen 5 versus 10 years, which showed giving for 5 years more in at least high risk patient node positive decreased the risk even up to 25 years. So that was an example of recognizing higher risk and then treatment which reduced the risk even down the lane, even up to 25 years. So let's look at them piecemeal. Let's look at the TNM first. We recognize that despite current standard of care, we will experience distant recurrences in those with N1 disease and sometimes even N0. I'm looking at 20 years. Even there's a 22% risk as N0 going to 31 at N1 and half 52% at N2. Now you could argue 20 years is a long time, but well, breast cancer world is about a long time because early on, at least this group, as I said, seems to be doing well. Do note though that N2 disease at even 5 years is sitting at 1/5 patient. So it's not entirely a benign disease, but yes, in terms of memory, patients come, we treat in the immediate next 18 months, they are fine. But when we keep following them, there is a fair amount of recurrence. But this is very interesting that it's not only the node, but the T size. And again, there's been a lot of debate where the true biologists say that the size is not as important as node, but it is. And it keeps coming back to us that as T size go up on a node to node basis, if you notice T2N0 versus T1N0, it goes from 4, 8, 13 and 18% to 9, 16, 23 and 29%. So there's a clear jump on a T size increase, even on a node to node basis. And of course, when both of them join together, you can see that for T2N2 tumors, almost close to 60% will recur in the 2 decades that follow. This was the interesting NATLI data that demonstrated that even in the N0 subgroup, remember this is stage 2, this is the group where we generally go back with a very positive thumbs up. There is a fair amount of recurrence for even N0 group, and therefore that has to be watched carefully with other risk factors. So this is really what you want to tee out, who to give, who not to give, is that what seems like a low risk group, what are the other factors that we can look at and say whether this is actually not so low risk as we presume just by looking at T and N and TNM staging. This speaks about the mortality risk for patients with HR positive, HER2 negative. And actually, if you look at it carefully, the grade 3, the stage 3, obviously, the node positive and the tumor size all independently and together are risk factors. So it comes back to TNM, TNN, and then finally the grade. These are old factors. This is what physicians, breast oncologists have been following for years together, and it has stuck with us that high T, high N, and high grade have a meaning. This is data again showing that just by an increase in grade, we are seeing an increase in risk of recurrence from at 10 years from 245, but at 20 years from 10, 13 to almost 17% just by grade. This was a very interesting article, Big 198 analysis of grade. Look at the grade 1 versus 3, grade 1 versus 2, grade 2 versus 3, and even grade missing. And you see the hazard ratios climb as far as 2.43. So there's a significant increase of grade 1 versus grade 3, and therefore T and grade independently and together make even a stage 2 worse. The new factors, key 67, and I think we have had lots of discussion on that. The launch of abemaciclib, in fact, was approved with a key 67 or more than 20% in the cohort 1. We'll just talk about that in a minute. But this is very interesting data coming out that in stage 2 patients, in stage 3 patients, both looking at a key 67 more than 20%, and in fact, key between 10 and 19 are looking at a higher risk than not. Look at the middle curve stage 2 patient, because this is the one which confuses us. This is the one which seems easy. And look at the key 67, under 10 goes from 0.86 to a 0.77. So there's a clear drop even in stage 2 patients as well as stage 1. But the drop is significant when it comes to stage 3, and therefore it becomes very clear that actually these things do combine together. When you look at only grade to grade basis, and we look at grade 2 and stage 2, as we said, grade 2 patients look at a drop going from 0.89 for key less than 10 to 0.78. That's a big drop in grade 2 patients. The big problem with key 67 is the reproducibility issues, which exist somewhat with grading, but certainly with key 67. There was a lot of discussion about half a decade to a decade ago, which spoke about IHC4, and the big problem of using that as a very easy, scalable model across was to do with the key 67 not being as reproducible as we would have liked to be. And this was both a training issue as well as the fact that there are histopathological differences between tumor to tumor. And I think that led to the question of molecular profiling and gene expression. And we were again very upbeat that this will certainly be the one central theme that will remain. I do remember 10 years ago, almost at San Antonio, where there was a debate whether the ER, PR, HER2, the IHC4, and the molecular will in fact triumph the TNM and patient's factors. And the answer at that time was no. It is still no. But this is interesting. St. Gallen's subtype for histological grading showed two things here, that for patients who are at all patients, the grade 2, grade 3 obviously are worse. Luminal B is obviously worse than luminal A. But notice the graph before where the PR status and the Ki67 are showing some level of increased hazard ratio, but the P remains 0.21 in 1 and 0.06. So we've not been able to prove that using Ki67 and PR status, while clearly these are links. And when you put it all together, I guess it makes sense. And we'll talk about that in a minute, but molecular testing first. Oncotype DX has shown somewhat high evidence quality because of the numbers and the data and prospective studying, and is therefore strongly recommended, especially in postmenopausal women, as a method in node negative to predict, so both being prognostic and predictive. While in 1 to 3, it is still high. There is insufficient with the NEGM paper showing that under 50, it actually was not predictive, and therefore we continue to give chemotherapy node positive, but in postmenopausal it was. And I wonder, as studies more mature, will it become one of the ways to study the role of the new PARP inhibitors and CDK inhibitors? And there are studies undergoing to use this as a method of deciding who to and who not to. Putting it all together, I think this is a good summary for any students out there. There is a kind of a multitude or a whole schema approach. You look at the anatomic risk, which is the T and the N size. You, of course, look at the grading, which is all critical. Each onco center does this extremely well, including in our part of the world. I very proudly say that our quality of histopathology is fantastic. The key 67, I think, is extremely interesting, but the reproducibility does remain a problem. The ER/PR expression is important. The moderate to low ER, while still positive, may not be as low risk as a ER of 8. The PR remains debatable. I personally believe that a very high PR expression is somewhat prognostic, at least. The genotyping is going to come, but do not forget that the postmenopausal and age as an attribute on risk, and a younger patient premenopausal, especially under 40, do badly. So that does add an overall risk to your profile. Recent clinical trials have been very interesting. The Olympia, the addition of PARP inhibitor, for germline BRCA1, BRCA2 patients. We classified this schema where neoadjuvant group, a patient with TNBC and HR positive with a CPS EEG score. I'll talk about that in a minute. More than 3 when given PARP inhibitors showed an improvement. These were high risk group. Similarly, in adjuvant TNBC plus anybody T2N1, but also HR positive with more than 4 lymph nodes. These are very high risk group, showed a benefit. Monarch E, as I said, picked up 2 cohorts. Cohort 1 was more than 4 lymph nodes, very high risk, or more than 1 to 3 lymph nodes, but with at least a grade 3 tumor or a size more than 5. The cohort 2 was entirely based on KI more than 20 almost, because they picked up the 1 to 3 with KI more than 20, trying to see that even if the grade is low, tumor size is less than 5, the KI matters. And in fact, the approval was based on that. I think the approval should have been based on all comers, but that's a debate for another day. NATALEE is very interesting. It has picked up actually stage 2 patients also. So this is a lower risk than Monarchy, and this debate is now ongoing where they picked up an N0 with a grade 3. So look at how grade is being put as high importance in NATALEE, a grade 2 with a high KI. So they are still saying KI is important. Or an oncotype DX recurrence risk more than 20 seconds. We want to look at this data when it finally matures exclusively what happened to this subgroup. And I think that will be very, very interesting to see the change in that. They also picked up the N1, stage 2B and stage 3 patients. And I think we will see more and more data emerge out of both these trials, Monarchy and NATALEE. And that will change a little bit of what we do. My key takeaways in last 2-3 minutes, the new treatment options now available for hormone receptor HER2 negative EBC. While the base has not changed in the last 2 decades, we are seeing some new changes, and that will change the landscape as we are all seeing that. The risk of early, but more so the late recurrence is real. And as we said, it is encompassing of everything, the age, the profile, the menopausal status, but also the T size, the N, the grade, and finally the KI and the molecular profiling as well. I guess the BRCA and the HRR will add to that. The risks exist even in patients with lower nodal status, especially the high grade, high K, high molecular type. So don't presume that if you're small t, small n, you will actually get away. Follow these patients regularly for a longer time, even if the therapy is not extended. And lastly, but most importantly, there is a significance of clinical prognostic markers, but I guess we need more information coming out of that. And with that, the advances in risk stratification techniques, such as the Olympia, which is almost a new schema, Monarchy and NATALEE, these things, at some point, my guess is an amalgamate. We put together a high risk versus a low risk approach and finally decide who to and who not to consider for therapies such as the PARP inhibitors and CDK, which Dr. Hope Rugo, I'm sure, will give us a lot more insight in the next talk to come. Thank you very much.
Thank you, Dr. Rohatgi, for that wonderful talk. And so, Dr. Bhawna, would you mind introducing Dr. Hope Rugo, who is going to be our next speaker?
Sure. Thank you, Dr. Vishwanath. It gives me great pleasure to introduce Dr. Hope Rugo, who is very familiar with India, and we see her every year at Year in Review. Dr. Rugo is the Winterhoff Family Endowed Professor and Director in Breast Cancer at the UCSF, Helen Diller Family Comprehensive Cancer Center. She's the PI of multiple clinical trials focusing on treatments in breast cancer. She's an active member of Translational Breast Cancer Research Consortium, Alliance Breast Committee, ASCO, and serves in leadership roles in various research groups and committees. And she has more than 1,000 publications in peer-reviewed journals. Welcome, Hope, and looking forward to listening to you.
Thank you very much. Can you hear me?
Yes, we can.
Okay, great. So let me just get my slides up. And thank you for the kind introduction. And thank you so much for inviting me to speak also. Now, why is it that, hold on one second, sorry. It has something here, sorry, says something new. There's something new about the way, I think, let's see if this will work.
We can see your slides.
Yeah, but I don't think these are the right slides. I can't get to the slides I want. So hold on one second. Sorry, I think that there's a new, okay, I think I have it now. There's a new Zoom and it made me update to Zoom, so that's the problem. Okay, there we go. Now you can see them, right?
Yes.
Okay, good. Anyway, it's a great pleasure to be talking here, and I look forward to our case discussions also. That will be a lot of fun. And that last talk was perfect as a start to the discussion of CDK4/6 inhibitors, really very nicely done, and discussion about something that's, I think, really important to all of us, trying to understand how we assess risk for patients. And I think, you know, we need, of course, a lot more risk stratification, both at diagnosis and then over time. And there's, of course, a lot of work going on looking at minimal residual disease and ctDNA, et cetera. But what we're focusing on today is really understanding when we first see a patient and understand their response potentially to chemotherapy in the neoadjuvant setting, or they've just had surgery. How do we assess their risk and how do we best treat them? And so we heard a lot about how to assess risk. And what we know is that the risk of recurrence with optimal adjuvant endocrine therapy and even with optimal chemotherapy using our gene expression profiles and pathologic risk, as well as age, we still see this late recurrence. And I think that also what's important when we look at this really is, you know, important data from the early breast cancer trialist group is that if you look at the first 5 years and you look at recurrence, because we know patients can live a while, 5+ years now, after diagnosis of metastatic hormone receptor positive disease, that if you look in this first 5 years, there's even a very big recurrence risk here, and it just continues over time. So, of course, our interest has been by extending adjuvant endocrine therapy and by trying to understand who benefits from chemotherapy to try and reduce that risk. So, as you heard earlier, there, you know, it was a challenge to try and figure out who to treat with the addition of CDK4/6 inhibitor, given the remarkable data and tolerance that we'd seen in the metastatic setting and improvement in overall survival in the first-line metastatic setting. And if you look at this data, it's data from the HiCam group. And what they did was look at patients based on their node status. So here you can see at least 4 positive nodes, or the group who had 1 to 3 positive nodes in grade 3 histology, and then 1 to 3 positive nodes in a big tumor size. And the reason why this data is so important is that if you're designing a trial, you know, how we design trials plays such a big role in what we learn from the studies, and it also plays a role in our ability to do these trials. So if you want to do a trial in patients with early stage hormone receptor positive disease, you're really limited by the fact that you need many thousands of patients, and it could take 10 years or more to try and see an outcome. Looking at those curves before, we know the natural history is a long duration of recurrence risk. So you want to be, I mean, these drugs go off patent eventually, and you really need to get information early. And we also want to understand who are the patients who recur early. So understanding this, if you look at these first 5 years, you can see that there's a large number of patients who are recurring in these first 5 years. So if you were going to do a study and look at adding something to adjuvant endocrine therapy, and we're putting chemotherapy out of the thinking here, you'd want to try and assess patients who have the highest risk disease. So this actually led to the selection of risk criteria for Monarch E. Because of the success of CDK4/6 inhibitors in the metastatic setting, all 3 CDK4/6 inhibitors were studied in very different populations in the early stage setting. Penelope B tried to look at high-risk patients by looking at patients who had residual disease and high-risk features after neoadjuvant therapy. And Pallas looked at 2 years of palbociclib, including a relatively lower risk population. Interestingly, neither of these studies showed any benefit, even with longer-term follow-up and even with looking at specific high-risk subgroups within the trial, although they weren't really powered to look at those groups. Monarch E and Natalie data followed and actually mirrored what we'd seen in the metastatic setting, in that we did see clinically important and statistically significant benefits from the addition of the CDK4/6 inhibitors. So Monarchy, as I mentioned, focused on the high-risk group. And you heard earlier about the risk stratification that was used in this study. So these patients had node-positive breast cancer, and then they were further defined by having high risk of early recurrence. So 4 or more positive nodes, or 1 to 3 positive nodes, and at least grade 3 disease, or a tumor size of 5 centimeters or greater. But as you saw earlier, we've seen for a long time that Ki67 seemed to predict a higher risk of recurrence in hormone receptor positive breast cancer. And there's been a lot of work on optimizing the ability to evaluate Ki67 by pathologists worldwide, and guidelines have been published. And now people use similar antibodies. So the ability to test Ki67 has improved a lot over the last decade. So that cohort 2 was a small cohort, an exploratory cohort, actually, to look at patients who had still node positive disease, so 1 to 3 positive nodes, but they had to have a centrally defined Ki67 of 20% or greater. They could not have grade 3 disease or a tumor that was greater than 5 centimeters. So the idea was you were taking patients who wouldn't have fit into cohort 1, but still had positive nodes and a high Ki67. And we enrolled in this group of patients relatively later in the whole trial conduct. Interestingly, that also represented 9% of the total population. That was 5,600 patients. So you can imagine this as a small exploratory group. The primary endpoint for this trial, which randomized patients to 2 years of abemaciclib with endocrine therapy or endocrine therapy alone, was invasive disease-free survival. And then there were many secondary endpoints, as you can see in the bottom of this slide. What's important also to think about the endocrine therapy here, because that'll help us when we're thinking about the cases, is that these patients could take any endocrine therapy. So they could take a non-steroidal aromatase inhibitor, or they could take tamoxifen. So patients were allowed any choice, essentially, of standard endocrine therapy. We've now seen published in Lancet Oncology in 2023 this really curious finding, which I think we all hoped for but didn't know would actually occur, which is a carryover effect. And then I'll show you the 5-year data with further effect. So what you can see is these are the real curves at the top, and this is an inset that starts at 70%. But what you can see here is in red is the abemaciclib duration, but the benefit from taking 2 years of abemaciclib extends and increases far after the end of that therapy. So what you can see is that the absolute benefit in IDFS at 4 years was 6.4%, compared to 2.8% at 2 years and 4.8% at 3 years. And then, of course, the key endpoint for us in medical oncology is reducing distant recurrence-free survival. Remember when we first saw the data from the extended duration of letrozole from 10 to 15 years and realized that the benefit was all in reducing contralateral breast cancers. And I think if you develop a small curable contralateral breast cancer, might be better actually than taking 15 years of an AI, given the side effects. So, this is a really important endpoint for us and for our patients. And here you can see that the carryover effect also applies to patients in terms of distant relapse-free survival, with 5.9% at 4 years and then 2.5% at 2 years, encouraging to see that benefit early, and 4.1% at 3 years. And then we were really excited to see the data now published in JCO this year, looking at a 5-year median follow-up of 2 years of abemaciclib treatment. And what's really nice to see here and spelled out with these differences is that the absolute benefit continues to increase with a 7.6% improvement. And as you can see here, I mean, looking at absolutes is not exactly the way Kaplan-Meier curves were intended to be evaluated, but you can see that if you just go from 4 to 5 years, you're further seeing a benefit. And abemaciclib treatment is long gone. And the same is true for distant recurrence-free survival, with now a 6.7% absolute benefit in distant recurrence-free survival. So to me, this was some of the most exciting data we've seen in early stage breast cancer in a very long time, that you could just take 2 years and see this benefit. So then the selected subgroups is always important. Is there a group of patients who benefit more or less? Keeping in mind the eligibility for Monarch E. So you can see that across the board, there were very few patients who had an ECOG performance status of 1, as you would expect, so very difficult to interpret. But really, in all of the subgroups, you can see that there was benefit from abemaciclib. So let's look at the other ones that have confidence intervals that cross 1. There was also a small number of patients who are 65 or older. I'll show you that data in just a moment. And that's really because we don't see as much of that high-risk disease, thankfully, in older patients, certainly not grade 3 histology. There were less patients with stage 2 disease, but you can see that relatively the benefit remains in this group of patients. And then, as you would expect, there was only a very small number of patients with grade 1 disease. And again, these are patients where you're going to see events later rather than earlier. But it was encouraging that with patients with high-risk disease, even with tumors under 2 centimeters, we saw this benefit, and we saw it across node positivity, even in patients, smaller numbers, but 10 or more positive nodes, very high risk, and regardless of whether patients took tamoxifen or aromatase inhibitors. Now, what about overall survival? This is still very early, thankfully, for looking at overall survival for patients with hormone receptor positive disease. And now we have, at least in some parts of the world, antibody drug conjugates that are further improving overall survival in the metastatic setting. But we can look at the endpoint of patients who are alive with metastatic disease. And this was also, to me, a very impactful endpoint. So at 5 years, this is the overall survival interim analysis 3, cutoff of just July of last year. You can see that there are many more patients in green here who are alive with metastatic disease who received endocrine therapy versus those who received abemaciclib and endocrine therapy. So this is also, I think, a very important endpoint. And of course, we'll see what this happens to this over time. We do have better therapies now in the metastatic setting, although again, access to these therapies is quite variable around the world, but you still die of metastatic breast cancer. So I think we'll have to see this difference in deaths due to breast cancer in the long term. So what about Ki-67? Can we look at cohort 2? Well, this is a small group, 253 and 264 patients, and there's very small number of events. And this is even at 5 years. So it is, I think, I'll show you in a moment, a very important prognostic factor, but it's a small number of patients and the number of events is still small to really tell a difference here if you look at this cohort alone. But if you look at cohort 1, I think what's really interesting is looking at this Ki-67 high or low group. So remember, these patients were eligible regardless of their Ki-67, but that was evaluated centrally. And what you can see is that the benefit from abemaciclib occurs regardless of the Ki-67. So if you just compare the hazard ratios between these groups for IDFS and DRFS, they are identical. So that's really encouraging. But if you look at the actual 5-year IDFS rates, what you can see is that in patients who have a high Ki-67, regardless of what their treatment, that their outcome is worse. But what's really important here is if you look at this group who got endocrine therapy alone, their outcome is really very poor just at 5 years with a 25% rate of distant recurrence. And here, as 72% 5-year IDFS. In the Ki-67 low group, it is better, but still not great for these patients. And this is shown graphically. This is the 4-year data because we did separate it out at that time in the way the data was shown. And you can see that the benefit is very similar, regardless of Ki-67, but the curve is shifted downward in patients who have a high Ki-67. So I think that that's very important and impactful data. And in fact, this data led to the US FDA dropping the key 67 as the key criteria for approval in their initial approval of adjuvant abemaciclib. Now it really uses the Monarch E criteria in cohort 1 and eliminates key 67. So what about older patients? This is a group of patients we treat in our clinics, and it's important to know how patients really tolerate this treatment and their benefit over time. The benefit in older patients appeared to be quite similar in this very interesting presentation by Erica Hamilton last year at ASCO. But there was more toxicity in older patients, and we'd seen this across the board, even in the metastatic setting with CDK4/6 inhibitors. And then also there were more discontinuations without prior dose reduction in older patients. So they started at the full dose. They had mostly, I think, diarrhea that led to the discontinuation of treatment. But interestingly, if you just look at interruptions and reductions, what we're seeing is there are still more reductions and more interruptions in the older patients. But it does suggest that if we really interrupted and dose reduced early, that it would be much better for our older patients. And we could talk about in our discussion whether or not for a much older patient, one might consider even starting at a lower dose. Somebody who has a poor performance status and a high-risk cancer, where you really do want to try to use abemaciclib, you might want to try several strategies in making this more tolerable for our patients. In this presentation, they also looked at quality of life. And interestingly, I think it highlights the difficulty in looking at quality of life in our patients and the problems with some of the accumulation of the data from the instruments we use now, because quality of life didn't differ at all based on age. And I think this also has to do with this early discontinuation rate. So some patients just discontinued in the first 3 months. And in fact, that was the greatest rate of discontinuations in both Monarchy and Natalie. And we're going to see a lot more data on this in presentations later this year. But then you're not going to reflect any difference in quality of life because they've stopped by 3 months. But if we can make it more tolerable for those patients, we won't see the discontinuations and will benefit more patients. In terms of the older patients in toxicity, older and younger patients, this is the updated data. And I think one of the questions a lot of my patients ask me is, if I take 2 years of this drug, and there's a lot of discussion on chat. One of our advocate patients was telling me recently, because there's a lot of discussion about how the diarrhea is difficult and lots of issues, and are you going to have long-term toxicities? And I think that this data is really important, because when you look at the overall survival interim analysis endpoints, there is no long-term toxicity in these patients. So the toxicities all occur while you're taking the drug, they resolve afterwards, and there's no long-term toxicities. Now, one of the things I wanted to talk about before I talk about the specific toxicities that were seen in Monarch is some really interesting data which was presented at San Antonio last year by Nick Turner. And here they looked at the different risk groups by genomic criteria. So here's inferred oncotype risk scores, because they looked at an oncotype RNA score, not the real oncotype, and they looked at less than equal 25 or greater than 25 to try and understand whether or not there was a differential benefit, and we should use oncotype to try and decide about benefit of abemaciclib. But here you can see that the benefit, there was only a small biomarker subset here. The benefit appeared to be relatively consistent across the different oncotype scores. And then I think also interestingly, and I think a big question for all of us, was whether the benefit would be the same across different mutations that occur in these tumors, which we know confer worse risk in the metastatic setting. And here you can see that PIK3CA mutations, CCND1, TP53, all of these patients had very similar benefits, regardless of mutation status or not. So now let's talk about the safety. And here's the mature safety findings from a publication from Lancet Oncology in 2023. And then we also published details in Annals of Oncology in 2022 based on the endocrine therapy. You can see, as we know, that the most common toxicity is diarrhea, then fatigue, and some neutropenia. And you can see some is grade 3, requiring dose adjustments in these patients who take continuous CDK4/6 inhibitor therapy. But some of the other toxicities which are important are interstitial lung disease, which is increased by about 2% by abemaciclib. And interestingly, we see it across all the CDK4/6 inhibitors. I have yet to see any ILD in my patients who are taking it in the early stage setting, but we don't get routine CT scans, and we don't change CDK4/6 inhibitor therapy if we have grade 1 ILD, unlike the antibody drug conjugate trastuzumab deruxtecan, where we do hold and treat in general. And that's because very few patients go on to have symptomatic ILD. But if they do have symptomatic ILD, as shown here, it's important to hold therapy, treat with steroids. We don't actually know what the risk is in retreating. I have some limited experience in one patient. I've only had one patient in the metastatic setting, and I treated her with, she received abemaciclib and then ribociclib. And when she received ribociclib after she recovered from the ILD, after about 2 months, the ILD recurred. She then went on to palbociclib and stayed on it for 2 years. So I think that there may be some variable risk in these very rare situations with ILD. In terms of venous thromboembolic disease, we know that abemaciclib is associated with a slight increased risk. This increased risk is predominantly seen with tamoxifen. So I don't use tamoxifen with abemaciclib in the early stage setting, although you certainly can. I think you have to be really aware of the risk of venous thromboembolic disease, although it's 4%. We certainly don't want to increase our risk for our patients and commit them to anticoagulation. In the metastatic setting, when I do have to give abema with tamoxifen, I usually use a low anticoagulant. There's some increase in transaminases, but very low, grade 3 or greater. And in those patients, I haven't had to discontinue therapy. So with adjuvant abemaciclib for 2 years, we've seen increasing benefit over time. It's the first carryover effect to be seen. OS is going to take a long time, but the DRFS benefit to me is quite convincing. Older patients seem to have similar efficacy, and also, as I mentioned, similar quality of life, but higher discontinuation rates without dose reductions. And, it's important to inform best patient management so that we can optimize our patient's outcome. Dose reducing early, you can always going up later. And as I mentioned earlier, starting a frailer patient at a lower dose. So then we saw the data from NATALY, which was so exciting. The phase 3 NATALY data, which I think further confirmed the benefit of CDK4/6 inhibitors in the treatment of early stage hormone receptor positive breast cancer. The eligibility criteria for NATALY was different than MONARCH, and also the treatment was different. Patients received ribociclib for 3 years rather than 2 years. They could not receive tamoxifen because of the known slightly increased risk of prolonged QT with tamoxifen and ribo, and they could only receive non-steroidal aromatase inhibitors, not exemestane. Patients could have anatomic stage 2B or stage 3. So you could have a T2 node negative disease, but you had to have some high risk feature. So grade 2 and Ki67 of 20% or greater, or a Oncotype DX breast recurrence score of 26 or greater, or high risk genomic risk profiling for other tests, or a grade 3 disease. And then otherwise, if you were T2 N1 disease qualified. So this is a study which also included a lower risk T2 N0 group of patients with some high-risk criteria. The primary endpoint also IDFS, and this is data, of course, I'm presenting with Dr. Hortobagyi on the webcast who presented this data. So I think what's important is understanding the difference in NATALY. We have the broad range, including patients with no nodes who still have a high risk that goes out for several decades. And then the other thing that's different about ribociclib compared to its approval in metastatic disease is 400 milligrams was used because about 60 or more % of patients dose reduced in the metastatic setting, and they had identical outcome in terms of benefit in PFS and OS. So it was felt to be very safe to use a lower dose, and it would be less difficult for patients in terms of neutropenia. They also were interested in whether or not it would impact QT prolongation. And then 3 years, because of this idea of the very long duration of risk for patients with ER-positive breast cancer, and you could drive more tumor cells into irreversible senescence so that they will not recur late. So who were the patients who were enrolled? How many node-negative patients were enrolled? So here you can see there's a few NX patients, but N0 was about 27, 28, 9, so overall 28% of patients in this study. And I think that's really the main reason to show this slide. Stage 2A, about 20% of patients. So some of the patients with node-negative disease had larger tumors. So keep in mind about a fifth of the patients were node negative and T2. Also, premenopausal women, about a little less than half of the patient population. So also really important, I think, to look at in this patient group. Most patients received prior chemotherapy, so 88%. This was also true in Monarch because you have a high-risk group of patients. There was a group of patients who discontinued at both the second interim analysis and then with about 5 more months of follow-up, the final protocol specified invasive disease-free survival analysis that was presented at San Antonio. This data cutoff was also in July of 23. And what you can see is that there was a similar number of patients, only 5 months difference, but a little under 20% who discontinued due to adverse events. And again, this was all mostly early in the course of the treatment, and we'll see more data on this in the near future later this year, specifically looking at safety and dose reductions and discontinuations. But it is interesting, you know, we really have to get our patients through those first few months. So here's the updated IDFS data in the patient population, showing now it's an additional 5.6 months, an absolute benefit in invasive disease-free survival at 3 years of 3.3%, and the relative risk reduction is by hazard ratio, the hazard ratio of 0.749, very encouraging. If we look at anatomic stage and node status, it's also really helpful here. You can see that if you look at stage 2 disease, you know, patients are doing pretty well at 3 years, so we need to go on with longer follow-up. But if you look at stage 3 disease, we're really seeing a lot of recurrence in this first 3 years, a median of 3 years of follow-up. You know, only 84% of the patients who've received endocrine therapy alone are free from recurrence. But you can see that it's 88% if you took the ribociclib, and for sure we haven't seen the absolute long-term benefit as yet. That delta is 4.3%, which I think is clinically very important. And then looking at node negative disease, also low number of events, a small delta now at 39, almost 39 months of follow-up. And the patients who had node positive disease, again, the follow-up here is shorter. And the reason for that is because Natalie added on an additional 1,000 patients with very high-risk disease at the last year of treatment. It recruited very rapidly, but it was because the data in Monarch E had come out showing benefit in high-risk patients, and they wanted to be sure to power for high-risk disease. So here you can see this is early, but the delta is still greater than node negative disease, 3.2%, showing how important this is. And this just shows you the graphic representation of this now. Now, interestingly, the hazard ratios in stage 2 and stage 3 are relatively similar, which is encouraging to see better benefit over time in the lower risk population. And then node status, also similar. The hazard ratios are relatively similar, suggesting that we're going to continue to see changes over time in this group of patients. So what about distant disease-free survival? Also a benefit of, as you can see here, there's very few events. So it's 90 versus about 93% here. So we're seeing a small delta at this time in distant disease-free survival, but still I think we're seeing a benefit, and the hazard ratio is 0.749 with a significant p-value at 0.001. So it is intriguing that we're already seeing a difference similar to Monarch E with just 3 years of follow-up. In terms of toxicity, neutropenia is the most common toxicity, as you can see here, and 44% of patients had grade 3 or greater neutropenia despite using 400 milligrams. But we found that this is very easy to manage, and we don't really see any increase in febrile neutropenia, 0.3% in the entire trial. One of the interesting adverse events with ribociclib is liver-related adverse events, and this is primarily transaminitis. We rarely see elevations in bilirubin. I recently had a single patient with a dramatic rise in bilirubin on ribociclib in the metastatic setting after 2 months of treatment. Interestingly, that also responds very nicely to steroids. It's a drug-induced hepatic injury, inflammatory. Patients recover, which is very nice, but it depends on the degree of liver enzyme elevation when you can retreat, because this can take several months to recover. So it's important to monitor liver enzymes in these patients so that you can stop early and allow patients to restart potentially at a lower dose in order to benefit in the metastatic setting. QT interval prolongation was low, but it still was increased even using the lower dose. But there were, of course, no patients who had torsade. And ILD pneumonitis was the low rate we've seen in the metastatic setting, 1.5%. So very good. The most frequent reason for discontinuation, as you would expect, is the liver-related adverse events, primarily transaminitis. And here you can see the additional data, which I just wanted to show you. So I'm showing you this part of it, which is that there EKG-related QT prolongation in the pooled monolysis studies and then NATALY. So it's definitely decreased, but you still see it. And then this shows you the neutropenia also. As you can see, it's really dramatically decreased. Neutropenia here, QT prolongation here, and then you're seeing this same differential. So NATALY is the second phase 3 trial to show benefit from the addition of CDK4/6 inhibitors, very encouraging therapy. Really, we're making a dramatic advance in the treatment of patients with less patients living with metastatic disease. 400 milligram dose does appear safer than what we saw with 600 milligrams. We see less grade 3 neutropenia, but we're still seeing it. So we have to manage these patients carefully. And the optimal duration of therapy is still a question. A third of the patients discontinued ribociclib before 3 years. So we're hoping to see data later this year looking at when these patients discontinued. So did they discontinue when they got to 2 years, or did they discontinue in the first 3 months, which is where we have seen a lot of discontinuations because of that early toxicity that's not quickly managed. The follow-up is still short in the patients with low-risk disease. There's greater benefit in higher-risk disease now with shorter follow-up, as we would expect. This lower risk population is of great interest. So there's plans later this year to open a trial called the WIDER trial, which will include patients with low risk disease so we can better assess their benefit over the long term. I think this will be really interesting to see. How we're going to look at current guidelines is really important for patients with a high risk of recurrence. Right now, these are the FDA, NCCN, and ASCO guidelines. I have another slide, I think, that shows you additional guidelines in patients, yes, across ESMO as well, which I should show. And they basically look very similar here. You can have a Ki-67 of 20% or greater based on the ASCO guidelines. And that's what we generally do in clinical practice, at least in the US. But the FDA sort of settled on cohort 1. NCCN also cohort 1 allows the Ki-67 of 20% or greater as a consideration, and so does ESMO. So we really use the ESMO and ASCO guidelines for our plans now. What do we do with those patients with node negative disease that we know have high risk, or 1 to 3 positive nodes with high risk features that don't fit into this? Those patients, I think, will be enrolled in the WIDER trial. We'll see longer follow-up from NATALY, which I think will be important, and of course, potentially regulatory approval in the not too distant future. And all of this will help us. Curiously, there's a little delay in opening the WIDER trial because of nitrosamines found in the ribociclib. Now, if you have metastatic disease, you're getting 600 milligrams of ribociclib, and there's a little nitrosamines in the ribociclib, and it's totally fine by the FDA criteria. But the FDA has made very, very strict criteria to exposure to nitrosamines in early stage curable disease, where it's the amount that you're exposed to over 70 years. Now, they're only getting 3 years of ribociclib, but that amount per year is looked at over 70 years. And so they decided that that has to be reformulated, the FDA, to fit within their guidelines for nitrosamine exposure, which is a very curious finding because, again, you're not getting 70 years of exposure. But the ribociclib is now being reformulated, and then WIDER will open later this year. And then just lastly, of course, we can give patients who have germline BRCA mutations now olaparib based on the remarkable data from the Olympia study. So who are the hormone receptor positive patients who could go on non-PCR and other high-risk features, and then 4 or more positive nodes? We tend to treat patients who have residual disease after neoadjuvant therapy with olaparib. And I think one of the questions is whether you give olaparib and a CDK4/6 or a CDK4/6 inhibitor. Certainly the standard now is 2 years of abemaciclib for high-risk HR-positive, HER2-negative early-stage breast cancer. Now the Ki-67 requirement as the only regulatory approval by the FDA has been removed. NATALY is very supportive and adds the lower risk population, but we don't yet have enough data to use this as a standard of care. And then PARP inhibitors have remarkable data as well. So what are our questions? First is optimal duration of therapy. And I don't think we're ever going to have an answer to that because we're not going to randomize to 2 to 3 years, I don't think, in the near future. We need to understand the benefit in lower risk patients. And also, how long can you start? If a patient's a year out, a year and a half, 2 years, is that okay? Wider, we'll explore that as well. Management of toxicity and adherence is a critical issue that as providers, we have to play a very big role with education and management. And we also need to know if you got a CDK4/6 inhibitor and you have high-risk disease, should you still get 10 years of an endocrine agent, 7 years, 5 years? We don't know. And then for PARP inhibitors, can you give it to patients with germline PALB2 mutations? And how do we sequence therapy in high-risk patients? We have been giving them the PARP inhibitor for the first year, and in very high-risk patients, giving abemaciclib the year 2 and 3. This, of course, has no data to support it as yet, but it is a very important question. With that, I'll thank you and look forward to our discussion.
Thank you so much, Dr. Rugo, for wonderfully dissecting the monarchy and the Natalie data. And shifting gears, let's move on to the next session, the most eagerly awaited session, especially for the fellows. We request all our experts, Dr. Rugo, Dr. Bhawna Sirohi, Dr. Hortobagyi, and Dr. Nitesh to give their expert opinions for the cases which will be presented by our fellows. So let us start with the first case. And we have two fellows, Dr. Muthulingesh Kumar, who is a final year DRNB resident at Apollo Hospitals, Bangalore, and Dr. Ramadevi Chakapalli, final year DM resident at MS Ramaya Medical College and Hospitals in Bangalore. So over to you, Dr. Muthu. You can start presenting the first case. Please be crisp with your case presentation and questions.
Good evening, experts and attendees. So I would like to thank Vishwanath sir and CPOEM Foundation for the great opportunity. So I'll be presenting a case with indication for adjuvant CDK4/6 inhibitors in ER positive, HER2 negative early breast cancer. So a 73 years old female postmenopausal with no known comorbidities. She has presented with lump in right breast since 3 months and lump in left breast since 2 months. So on examination, clinical stage, right breast T2N1 disease and left breast T2N0 disease. So on further investigations, mammogram with ultrasound correlation of right breast, it was suggestive of a right breast upper inner quadrant mass with spiculator margins with architectural distortion. So it was suggestive of BRATS 5. Next. And mammogram with ultrasound correlation of left breast, which was suggestive of upper outer quadrant spiculated mass with grouped punctate calcifications and distortion, which was BRATS 5 again. So core biopsy of the right breast lesion was suggestive of invasive lobular carcinoma grade 2 and no BNI, no LVI. On IHC, ER8, PR7, HER2 Ki67 of 8 to 10%. Core biopsy from the left breast mass lesion again suggestive of invasive lobular carcinoma grade 1 with no LVA, no PNI. IHC suggestive of strong ER8, PR7, HER2 Ki67 of 3 to 4%. So we went ahead with metastatic workup, which showed no disease elsewhere. So she has underwent right modified radical mastectomy with axillary lymph node dissection and left modified radical mastectomy with sentinel lymph node dissection. So going on to post-op histopathology. So from the right breast, tumor size is 2.6 by 2.1 by 1.5 centimeters. Again, invasive lobular carcinoma, tubulolobular variant, grade 2. Regional lymph nodes, 17 out of 20 lymph nodes showed metastatic deposit with ENE, and lymphovascular invasion was not identified. Pathological stage was T2N3A with stage 3C disease. And again, ER was 7, PR5, HER2 1+, Ki67, 8%. Left breast post-op histopathology showed tumor size of 3.4 by 2.0 by 2.0 centimeter. And again, it is invasive lobular carcinoma with grade 2. All the resected margins are free of tumor. And 0 by 2 lymph nodes showed metastasis. with LVSI positive T2N0 disease, stage 2A, ER8, PR7, HER2 0, key 67 of 8 to 10%. So she went ahead, received adjuvant chemotherapy with EC90 for 4 cycles, followed by paclitaxel 3 weekly for 4 cycles, and then completed adjuvant radiotherapy to right chest wall, axilla, and supraclav. So she was started on letrozole 2.5 mg OD daily for the period of 7 years, and she is planned for adjuvant CDK4/6 inhibitors as well. So we have some points for the discussion with experts pertaining to the case which I presented. So to summarize, she is a 75 years old female, no comorbidities, postmenopausal, bilateral CA breast. So right breast showed like grade 2 T2N3 disease, left breast grade 2 T2N0 disease. So the first question I would like to ask Professor Hortobagyi, there is indication for adjuvant CDK4/6 in view of N3 disease. So what would we prefer, like either Abima versus Ribo? How to choose the CDK4/6 inhibitor?
Well, thank you. Very interesting case. Unfortunate with 17 positive lymph nodes. So clearly her prognosis is quite concerning. So we have data with both abemaciclib and ribociclib, as very eloquently presented by Dr. Rugo a moment ago. So in theory, both would be indicated. At this point, ribociclib is not approved yet by the regulatory agencies. Assuming that both are available and on the market, there's the question in stage 3, which would be preferable, right? In the metastatic setting, my preference is to use ribociclib, simply because the side effect profile of ribociclib is more compatible with a better quality of life than that of abemaciclib. And leukopenia and neutropenia are largely asymptomatic, and in the absence of hepatic dysfunction, I think patients tend to tolerate that treatment better, especially at the 400 milligram dose. Diarrhea is not a very nice side effect, and most of our patients tend to object to that. So all things being equal, I would prefer ribociclib. Now, on an evidence-based analysis, we do not know whether there are any differences in the therapeutic efficacy of the two drugs, and only much longer follow-up, as pointed out by Dr. Rugo, will tell us whether there are indeed differences, not only in stage 3, but also in earlier stages.
Okay, sir. Thank you. So moving on to next question, I would like to ask Bhawna ma'am. So the rationale of ribociclib dosing of 400 mg, comparing the metastatic setting 600 mg, 3 weeks on, 1 week off, like.
So I think especially in this patient, I would also do germline testing because she has bilateral breast cancer.
Yes.
And I think it'll be great to discuss if the patient, I have a patient who's high risk and who's germline BRCA positive, whether, you know, how you, because this patient is very high risk and the adjuvant CDK4/6 inhibitors are justified. But if the patient is BRCA positive as well, how would you treat the patient? And I think the rationale for 400 milligram dosing is just toxicity, and is so that the tolerability is better for the patients in an adjuvant setting. I don't know if there's any other rationale for it. Maybe Dr. Rugo can elaborate on that.
Do you want me to speak?
Yes, yes.
Take that question.
I'd love to know. One question is if she was BRCA positive, and second is the dosing as well.
Right. I think, you know, it's interesting I thought it was very clever actually to use 400 milligrams, and we were all very supportive of that approach. We enrolled lots of patients in Monarchy and Natalie. And I think that it's really fascinating. In the metastatic setting, you can get people through things in the first few months much more easily than in the adjuvant setting. Remember that almost 90% of these patients had chemo, and they're just tired of everything. And a lot of people will say, "I feel that I am cured," and they just don't want to have additional toxicity, and they don't want that reminder that they have cancer all the time either. So there's a psychological and a physical impact. They're tired, they get hair thinning, etc. So starting with a tolerable dose for our patients is incredibly important. And starting at 400 milligrams, I think just, made NATALEE possible. I think at 600, we would have had a huge drop off in those first few months. People are coming off of chemo, they're coming off of radiation therapy. And then, there was really robust data from the metastatic setting that showed that even when you dropped to 400 milligrams early, that you really did get this same benefit in overall survival, which I think was just really encouraging and made that a very nice approach. I think that, the PARP, I'm going to say one other thing about the ribo and abema, which is that, people hate hair thinning. And we've been using low dose minoxidil, and it is just incredibly beneficial for patients, and they have no side effects. So they take, 2.5 milligrams. It's a tiny little dose of minoxidil, which as I tell people, this was a crummy antihypertensive, and so nobody uses it anymore. And one of the reasons it was crummy was, one, it didn't work well. Two, it caused hair growth. So, and people, it's interesting, they don't get a lot of facial hair growth with it, So one of my Asian patients didn't like it because she said it made her hair grow straight up, but that's the only complaint I've heard. So whether we give PARP inhibitors first or not, I think because if you have a germline BRCA mutation and you are assuming the cancer is related to a defect in homologous recombination, you've got this defect related to the homologous recombination not being effective, you would treat that first. So I think that, we give, and, I don't know that we have any other data than that to believe that that's the right way to go, but we have tended to give PARP inhibitors for the first year. And then again, for the very high risk patients, I have a patient with, 7 positive nodes, a young woman, I gave her also abema after a year. It's a long treatment course, but she's finishing up her 2 years of abemaciclib now. So, I think that would be my rationale. I would give the PARP inhibitor for somebody of lower risk. You could just go with the year of the PARP inhibitor, but I think I haven't heard anybody disagree with that on panels that I've been on.
Thank you.
Thank you, ma'am. So next, I would like to discuss about. So we see in our breast cancer trials, all the inclusion criteria says invasive carcinoma. Pertaining to our case, it is lobular invasive carcinoma. So any subgroup data on adjuvant or CDK4/6 inhibitors in particular subset of lobular invasive carcinoma? Over to Professor Rugo.
Who did you want to answer?
It's for you, Hope.
Okay. I think, lobular cancer is gaining in interest and has actually gained in interest already. Now there's been, I think, 2 years of a international invasive lobular cancer conference. There's a lot of interest in looking at the biology of lobular cancer, which is clearly very heterogeneous. I mean, about 15% of breast cancers, and we see this small percentage that have pleomorphic lobular cancer that's really very high-risk disease, high Ki67. And what we've been seeing in clinic is that these patients' tumors lose ER when they develop metastatic disease and can be really, really tough to treat. But the majority of patients we see have this kind of cancer, sort of a more classic, low proliferative hormone receptor positive lobular cancer, and they are very hormone sensitive. So for that reason, I would think that there's even, if anything, more reason to use the CDK4/6 inhibitor. And in looking at, lobular versus ductal cancers, which is difficult in these large trials, there is a benefit from, hormone therapy, aromatase inhibitors, as well as CDK4/6 inhibitors in lobular cancer. So right now, we don't have the differential to treat patients differently, but I think because they're so hormone sensitive, it's encouraging.
So actually, in 2018, the FDA did a pooled analysis of the metastatic trials and with CDK4/6 inhibitors, and they found that 264 patients with lobular and metastatic cancer. And the hazard ratio for that group was 0.58, so exactly the same as for the overall population and the rest of them. There are also a couple of small abstracts of retrospective reviews by single institutions that show something very similar. There's one in the Annals of Oncology in 2023, 30 patients treated with all three CDK4/6 inhibitors, and you find the results that you would expect from the overall population treated with a CDK4/6 inhibitor plus endocrine therapy. So I agree with Hope. There's no reason to look at them any differently from the invasive ductals.
Okay, sir. So the last question for this case. So if we have a case with a T2N0 grade 3 disease and K67 of 8 to 10% with recurrence score of less than 26. So Dr. Nitesh sir has explained the extensively. He has covered about the grade with the risk of recurrence. So are we ready to implement, because this grade 3 with T2N0 was one of the inclusion in the naturally data.
Okay.
So are we ready to start consider adjuvant in that?
So I think even coming back to the previous comment, I mean, the lobular we have debated because we've always seen that as that kind of low multiplying, low risk. But as Professor said, there's data in metastatic settings showing that lobular gained from addition of CDK, which was a bit of a surprise then. You know, we were all predicting that lobular may not because they're not mitotic tumors. That clearly shows that that statistics is important. That clearly shows that when a clinical trial is set up with some inclusion criteria, until that answer is given, we should follow that. And in that respect, NACLI is positive in an intention to treat analysis for grade 3 tumors. There's a reason why it's a grade 3 and not a grade 1, grade 2. So yes, my answer is yes. I was trying to show in my presentation how I still would trust our old standard TN and grade criteria over the Oncotype DX and the key. I guess the data will mature over time and we may change what we say. But as of now, my answer is yes.
Okay, sir. Thank you.
Thank you, Dr. Muthulingesh, for being crisp, and thank you all the experts. We move on to the second case. Over to you, Dr. Ramadevi. You can.
Good evening, one and all. I'll thank Dr. Santosh and Dr. Vishwanath and CPOEM for this wonderful opportunity. Coming to the second case of today's discussion. Next. A 48 years old married premenopausal female presented with the complaints of a progressive right breast lump since 6 months. On examination, there is a 3 to 4 centimeters hard non-tender lump in the right breast upper quadrant with a well-defined margins and a single 1 × 1 centimeter mobile non-tender right axillary lymph node with a clinical stage CT2 and N1M0. She underwent bilateral breast mammogram, which showed a ill-defined spiculated mass of 22 × 17 × 16 mm in size, which is involving the nipple areolar complex along with the few right axillary lymph nodes. And she underwent the core needle biopsy of that lump, which showed the invasive ductal carcinoma of breast grade 1, CNG score 5. And the IHC was done on the biopsy, which showed ER positive and PR positive and Her2 1+ negative and Ka67 of 45 to 50%. And metastatic workup was done with the FDG PET, which showed only the locoregional disease with the breast lump and the right axillary lymph node. And there is no other evidence of the distant mets. And the final diagnosis is a CT2 N1M0 with the stage 2B and CPS score of stage 2A. The patient underwent upfront surgery with the right MRM and axillary lymph node dissection, and the post-op HPE showed the central quadrant and central and upper quadrant mass of 5 × 4 × 2.5 centimeters with a histological type invasive ductal carcinoma grade 2. And DCIS is present, and the extent of the tumor is up to the skin free of tumor. And the nipple is free of tumor involvement with no Paget's disease, but LVI and PNI are present, and the regional lymph nodes are positive 31 out of 31 with extranodal extension. And the pathological stage is PT3 and N3A. And the patient received adjuvant chemotherapy with 4 cycles of taxane, followed by the 4 cycles of epirubicin with cyclophosphamide, 2 weekly dose lengths, followed by the adjuvant RT to the chest wall and the supraclavicular fossa. And she was kept on letrozole along with the leuprolide with a 3 monthly depot, along with the zoledronic acid 6 monthly. In view of the high-risk early breast cancer with hormone positive and HER2 negativity with a positive of more than 4 lymph nodes, patient was started on abemaciclib 150 mg BD. But we can able to start the drug only 13 months post-surgery in view of the financial constraints. However, with the dose of abemaciclib was reduced to 100 mg BD in view of grade 3 diarrhea, and she tolerated the dose of 100 mg BD. In view of early onset breast cancer, the patient was advised BRCA testing and she underwent, and the report came as positive for the BRCA1 mutation exon 23, which is heterozygous. Coming to the discussion part, I would like to ask Dr. Hortobagyi, what's the acceptable gap between the surgery and to start the adjuvant abemaciclib?
Very interesting question, and I do not know the answer. Now, having said that, all of the trials in the adjuvant setting were set up for the CDK4/6 inhibitor to start after completion of chemotherapy, which the majority of these patients receive. We make arbitrary decisions in designing clinical trials. We decided in the early days of adjuvant chemotherapy that we want to start adjuvant chemotherapy within 6 months of surgery. That turned out to be more and more complicated as with plastic surgery and radiation therapy being administered and whatnot. So when we came to the CDK4/6 inhibitor era, we are now willing to accept the 4 or 6 months of adjuvant chemotherapy plus radiation therapy for many of these patients. So they end up starting their abema or ribo 6, 8, 10, even 12 months after diagnosis. I don't know that it matters at this point. Everything I know about oncology suggests that the earlier you start, the better your results. But having said that, we have this embarrassment of riches with the PARP inhibitor, the CDK4/6 inhibitors, the radiation therapy and endocrine therapy, and we are just trying to make sense out of this. I think it will be really important for us to figure out, for instance, the question that Dr. Rugo answered earlier about what to do about PARP inhibitors and CDK4/6 inhibitors. There are excellent data to suggest that the combination of the two is actually synergistic, data that are available from breast cancer, from prostate cancer, and a variety of other malignancies in preclinical systems. There is no safety data for the combination, and therefore we are doing it in sequence. But ideally, those should be administered together. And until such a date as that is possible, we will continue to do the sequencing. So for instance, in this patient, we would also start, of course, after chemotherapy, we would start with the PARP inhibitor. And after a year of the PARP inhibitor, we would start the CDK4/6 inhibitor. Now that will be a year and a half after surgery or diagnosis. So if that's the best we can do, well, that's the best we can do for the time being. But I'm sure that that is not ideal biologically.
Thank you, sir. Coming to the second question, Dr. Nitesh, can you please explain the rationale behind continuous dosing of abemaciclib when compared to the interrupted dosing of other CDK4 inhibitors?
I think very early on in preclinical, we saw that because CDK4 inhibition was more selective than CDK6 inhibition of abemaciclib as compared to ribo and palbo, we saw that the neutropenia was lesser, and in fact that was the reason diarrhea was more. And because neutropenia was lesser, we tried the continuous dosing. And again, in vitro studies, the cell inhibition was in fact better when we compare. When you look at the laboratory studies and the cell lines, you see the continuous dosing was achieving a more prolonged curve of suppression, below the line. I don't think that clinically we can say that the continuous dosing is better than interrupted dosing, though. I don't think that you can say when you're comparing two different drugs, it's two different mechanisms. So I would not say that the continuous dosing in adjuvant setting would be a priority over interrupted dosing. I think that data will set if it ever does that. But in metastatic setting, we have kind of seen that it's been a very effective drug, as has been ribociclib. So I don't know how clinically impactful it is, but yes, in the cell lines, we were seeing a better CDK4 to CDK6 ratio.
Coming to the third question, Dr. Hope Rugo, can you please share your experience of the side effect profile of abemaciclib and what are the strategies of dose modification in the patients?
Absolutely. And of course, this is a really critical aspect of any CDK4/6 inhibitor, where and any drug we're giving patients where we're trying to optimize outcome. Just to comment one on the gap, I think, it's an interesting question because when we had the approval, we had patients who were, really high risk disease who were, a year and a half out and 5 years and 8 years out. I have a patient who's 10 years out, has maybe she's 8 years now. She had multiple positive nodes, but she has a BRCA2 mutation. So she's saying, should I take a year of olaparib now? And, we're in a data-free zone there. But I don't know what to tell her. And I'm still sort of prevaricating because I know her risk continues. And I have absolutely no idea what the benefit will be of taking a year of a PARP inhibitor. But I will say the PARP inhibitors are unique in the drugs we give in that we see this resistance developing very, very early in the metastatic setting, way too early. The patients have a fabulous response and then their tumor starts growing in some ways much faster than we see with the CDK4/6 inhibitors because you generate these reversion mutations and others. So I can see that there's some, rationale for late use. And for me, it's my cutoff when we first got these drugs approved was 2 years. So I would have no issue at all with a year and a half. But for the side effect profile, it's critical. And for abemaciclib specifically, the key issue for patients is diarrhea. They do get fatigue, they get hair thinning. As I mentioned, we manage the hair thinning with minoxidil, which is a cheap drug, thankfully, a very low. And you got to take it by mouth. You can't put that messy stuff on your head. It doesn't work at all, and people get very discouraged with it. And it usually looks like it's mainly for men, which is another problem. They have them for men and for women. The women one is more expensive in the US. That's one thing. I think the fatigue is, I think exercise really, really helps with the fatigue for patients. They manage pretty well if they exercise, and dose reduction helps. And occasionally taking a break from treatment, patients will go, they're going to go, and it kind of leads into the diarrhea management. They're going to go on a trip to Europe on a barge, go hiking up a big mountain, they just don't want to deal with the issue of constipation and diarrhea. Taking a break is just not going to hurt anyone. And I think, you really want to balance this with quality of life. So what do we do about the diarrhea? I warn patients, I tell them, do not take the pill until you have loperamide in your pocket. And this is really important. It's important with some of the other drugs we give as well. You just don't want somebody to start getting diarrhea and not having loperamide at home. This is not the time to be going to the, pharmacy. So I think that helps a lot. For older patients where I know the risks are higher, I do sometimes start at a lower dose, 100 BID. One of the advocates was saying that they're online talking about how everybody should start at 50 BID. I don't do that. I don't think there's any data to support it. But in most patients, I'll start at 150 twice a day because people tolerate it. How I manage that diarrhea is I say to patients, look, first let's get an idea of the diarrhea you have. Then let's start on a preventive regimen. You don't want to be doing a reactive approach. So the preventive regimen includes loperamide, but people are afraid of constipation, which is horrible. So we tell them, take a half a pill every day. Take a pill every other day. Put it in your bag, your purse, whatever you carry. If you're going to eat a big salad when you go out to lunch, take a half a pill before you eat that salad because you're going to get more diarrhea. And the trouble is the incontinence, the rush to need to go to the bathroom. That's the biggest issue. So I found that to be incredibly effective for patients. And then the neutropenia, we don't see a lot of, but I have to say I have a patient who had previous treatment for endometrial, I think it was endometrial sarcoma. She got a lot of nasty chemo. And she's always neutropenic. She has an ANC of about 950. So I decided our cutoff for her is 900. We don't see a lot of febrile neutropenia. She doesn't get any diarrhea. She's on the lowest dose, and we just don't worry about it too much. But for most patients, we'll take a break and restart and dose reduce, and that usually works.
If I might add here, how important it is for the physicians and the healthcare team to be very proactively involved, especially at the beginning of the of treatment, anti-cancer treatment, but especially oral treatments. If you go back to the adjuvant endocrine therapy trials, at the end of 5 years, 30 to 40% of patients had discontinued tamoxifen or an AI. And that is because we had gotten into the habit of giving them a prescription and say, come back in a month or in 3 months. We cannot do that. And with these drugs, which are more toxic, we need to be much more actively involved in encouraging patients, in sharing with them approaches to continue taking it, because by definition, a drug you don't take doesn't work. So it is really, really important for the PARP inhibitor, for the CDK4/6 inhibitor, for endocrine therapy, for capecitabine, if you use capecitabine. So all of these require proactive intervention by the healthcare team, especially at the beginning, because discontinuation happens mostly during the first 3 to 6 months.
Yes.
I think that fourth question was already discussed. And Dr. Hope Rugo, can you please tell us how long to continue that GnRH analogs for the ovarian function suppression in this patient?
It's so funny because we had a big conversation about this when we were talking about a trial which is looking at switching to an oral SERD. And, how do you deal with the OFS if you're going to continue the oral SERD for many years and you're supposed to be on OFS? And some people in the steering committee were saying, oh, they stop at 5 years. But in older patients, they continue the AI after 5 years. So that doesn't make any sense to me. If I'm continuing therapy in a very high-risk patient, I generally continue the GnRH analog as long as for ovarian function suppression, for as long as I'm going to give the aromatase inhibitor. In this patient, if she has a BRCA mutation, especially either BRCA1 or BRCA2, I think, if she's completed childbearing and because she has high-risk disease, you're probably going to be continuing therapy for longer than she would be thinking about having kids, and she was in her 40s anyway. I would talk to her about doing oophorectomy, which takes away that question because of her risk of ovarian cancer and peritoneal cancer. And I think that that in that situation, you just have to balance the risk and benefit of early menopause. But I would continue for 5 years, and then I would have a discussion about extending adjuvant endocrine therapy. And there's going to be a lot of data, I think, about looking at ctDNA and different kinds of endocrine therapies and whether or not, we find ESR1 mutations and all sorts of things in the future that might help direct us in terms of the optimal endocrine partner. But generally, we're not switching to tamoxifen unless patients have poor tolerance of an AI or for some other compelling reason. So we would continue the ovarian function suppression.
Yeah. Thank you, Dr. Ramadevi, and thank you all the experts for the wonderful case discussion. Now I request Dr. Santosh Kumar Devdas, one of the co-founders of CPOEM Foundation and professor at MS Ramaiah Medical College, to give the closing remarks.
Thank you, Dr. Vishwanath. It was a wonderful 1.5 hours of understanding breast cancer. Just to summarize, we initially started with a wonderful talk from Dr. Nitesh Rohatgi. He did touch upon TN staging and the grade that matter along with K67 to a certain extent in decision making. and oncotype scoring and menopausal status are also looked into for decision making in adjuvant setting. Dr. Hope Rugo, with her wonderful insights on Monarchy trial, which showed a 5-year IDFS and DRFS, and the benefit is increasing over time, and the use of abemaciclib in older patients, various insights into these nuances in clinical practice. And she did mention about the ILD risk in patients who are getting CDK4/6 inhibitors, and did show the Natalie data and the IDFS benefit that is seen with ribociclib. And she did touch upon various nuances in clinical practice of QTC prolongation and liver toxicity with the use of these drugs. I would like to conclude the webinar with a special mention of Dr. Hope Rugo, Dr. Nitesh Rohatgi, Dr. Gabriel Hortobagyi, Dr. Bhawna Sirohi, for spending their time, precious time with us, and the Novartis team, Dr. Disha Shetty, Dr. Kumardeep, and Dinesh, the residents who presented these cases, and these insights came through because of them. And the CPOEM team consisting of Rachan Shetty, Chandrakant, and Poonam Maurya, the ASCO team, Sarah Bachman and Jessica Williams, and the audience. I would like to invite all the audience who are visiting ASCO to our booth this year. The booth number is 10035. And if you have any questions or clarifications, please mail to us at contact@cpoem.org. Thank you. I would like to close the webinar. There are more questions in the chat box, but we couldn't answer them for just because of the paucity of time today. Thank you, one and all.
Thank you very much. Thank you. Bye-bye.
Thank you.